We have 20 or 25 minutes available for some panel discussion. I'd like to start by opening it up to the people who've been listening to the talks. And then later, if any of the panelists and speakers would like to add anything else to what they say or react, they'll be invited to do that also. But let's start with any questions or comments from the floor, including any you'd like to direct to Alta Sharo, who started us off this morning. Yes, Alta, please come up. Yes, Harvey Feinberg.
Thanks, Ralph. I'll just start with a question, John, to you, because I was struck in all of the presentations, we've heard about how desperate patients are grasping for hope. And in your study, you also pointed out that the clinical findings were met with high skepticism on the part of the medical or scientific community.
That's correct.
How do you reconcile, what ideas do you have to reconcile these extremes of skepticism on the part of the scientific community and desperate hope on the part of the patient community?
So interestingly, the hope aspect it still drives, no matter what the outcome, still drives the patient's and parents' point of view. So even no matter what the scientists and clinicians said in the community, they didn't care. So from the point of view of the public, they saw the hope, they saw the benefit, and in fact, one of the things that just came, I was listening to the last presentation, is that even when my patients die, and many of them will, the families console me. So even when they have the worst outcome, because I gave them a chance, that's all they wanted. And they will bypass what their physicians tell them. They will go directly to get that potential therapy. So from that point of view, even though my trials are the regulated trials and go through this typical phase 1-2 testing, what's interesting is because my focus is publishing the data, so that sets me up for then the negative scientific response, which invariably comes. As you may know, my main interest has been umbilical cord blood. And in the very beginning, that met with the exact same negative criticism, and only slowly did that change over time. But that's part of academic medicine, and I guess we're kind of used to it. But it is interesting how there's a dichotomy between the public versus the scientific community.
Yes, and then Rusty.
Just continuing that theme.
Is that Larry?
Sorry, can you use the microphone, because we have people who are on the web.
Is that Larry?
Sorry. Just continuing that theme of hope. John, maybe you'd say a little bit about how University of Minnesota fills that need for patients. I mean, we have our own sort of standards. And then Alta, given that this is such an important component of the whole response, do we have that sort of presence here? Do we have folks who are thinking about it from a psychiatric or psychological or social work or spiritual kind of presence? Because it seems like that's a really important component of this whole problem. How do you do it in Minnesota?
Well, okay, so to go, this actually leads into a discussion I think you want to bring up at some point, and that is that the most common phone call that I receive is for patients with neurologic injury asking for cord blood transplantation.
Right.
As the number of private cord blood units are banked, it's now becoming so more widely available, and because we do so many cord blood transplants for other indications, why won't I do it here? Well, in fact, one time I did do it, but I didn't do it as part of a study. I just did it because I just gave in, and because I could do it. But then the problem came up, especially now that cord blood is licensed and for one indication, parents are just saying, why can't I do it if it's autologous cord blood? Just give it and let me have the hope that it might work. However, once I change that into a study, which is what I want to do, then it initiates a whole other change in everything. So I can charge them, let's say, $5,000 or $20,000, to just give the infusion, and then forget them. They can go home and tell me maybe a phone call later. So how do I deal with it? Well, I actually don't. I still stick to, this is my way of doing it, the proof of concept first, then the clinical trial, and then report the outcome, because that's what I want to do. but there's lots of pressure out there. And I think maybe we need to reconsider how we're doing things, because the moment I change into a clinical trial, it's so much more costly.
Sure.
You know, and maybe we're not doing the right thing to some extent.
Well, I was really getting at, John, the idea of what are the institutional support systems that you have now. You know, at Children's Hospital, we have a similar, spectrum of need. Maybe not. We're not doing the EB, which is really, I applaud you for that. But fundamentally, there is an enormous need, and we try to fill it with kind of an interdisciplinary team of social workers, psychologists, chaplains, things like that. And I realize it's such a critical part of their whole response to this problem. I'm just hoping that this becomes,
Yeah. I didn't realize that's where you're going after. Yeah, I mean, there is a whole team of people that support these people that come long distance for these very drastic therapies. And so, yes, it requires a huge enterprise of people, as you pointed out.
It's sort of inadequately treated in medical education, at least. I think may have gotten better at certain centers, but it could also be something emphasized.
Before we go to Rusty, Tim, did you want to say something?
Yeah, I do want to. It goes a little bit to this point. I think we can't. And I'm curious what Alan says about this. We can't underestimate the pressure from the patient groups. There is incredible anger out there. I know Doug does too. I get a lot of hate mail, and it's from patients. They're furious with me. I've given public lectures where there have been people from the MS community yelling at me and swearing at me and sort of shouting me down. I know you've had similar experiences. So the pressure is absolutely intense. And so I think that, I'm curious what you have to say about that. And the second point I want to make is that it goes specifically to the George's comments. I'm curious of the role of the family physician. Now, in Canada, they play a big role in the healthcare system. I don't know about here. I think that they have, the sense is that patients go and talk to their family physicians. And Alan, we've had the exact same experience. If they give an equivocal answer, they take that as almost as an endorsement. So is there a role there for more definitive statements from family physicians? And if so, I'm curious how that would play out. I actually think that would be an interesting study. But family physicians clearly, I think, have an important role to play here. And involving the College of Physicians and Surgeons and these kinds of discussions, I think, would be very, very important in sort of empowering physicians to deal with these questions.
Alta, would you like to go ahead? Sorry, Rusty.
Yeah, very briefly, because I think it connects also to a comment that came in on email from somebody who's watching us through the webinar. One of the things that's a challenge here is going directly to what I think Dr. Petersen talked about with patients who said that taking some control made them feel better in and of itself, even if the actual response in the end was not some physical improvement. It's part of a much larger set of arguments that we've been having, at least in the United States, about the right of patients, or the asserted right of patients, to seek out whatever they want, especially if they've got terminal or degenerative conditions. We've even had litigation go all the way to the Supreme Court in the form of the Abigail Alliance case. And the basic argument had been, even if something is unproven to the regulatory authorities, even if it's unregulated by other mechanisms in professional societies or medical malpractice, even if not only is it unproven, but in fact every suspicion we have would suggest that it's not only unproven, but it is in fact ineffective and probably harmful, there is an argument from a more kind of libertarian point of view that in the end patients ought to be able to decide to take that chance for themselves. So it's a much bigger argument than just stem cell therapies. And there are many responses about the desire to not only protect public health and protect people from being flim-flammed, but also by providing the right incentives to encourage organized research to truly find out in the end what's going to work and what won't. But it's important, I think, to understand that these are bigger arguments that are not just spiritual, George, but they're really, at least in the U.S., they're assertions of a kind of political point of view that grows out of personal experience.
So I can certainly see that this is the issue, but I'm finding it difficult to get my hands on how big of an issue it is, the quantitative nature of it, and there is this emotional part to it. But what are the problems from a sociological point of view, a research point of view, getting? Is there data to be gotten here so that the numbers can be more quantitative? This is not to question the validity of the issue, but just how do we do that? How do we get a harder fix on the numbers?
Before one of you responds, I had the similar question, Rusty. The numbers that we saw were absolute numbers. I think it would help some of us to understand their relative size, relative to other kinds of, randomness in medicine, and how many patients are suffering in the first place, the relative value of the dollars compared to other situations. But please, if you could try to answer Rusty's question.
I think this is a great question. You're going to hate my answer. You really can't put your finger on it because it's very difficult to get a sense of the size of this industry. You don't know who's going. It's very, very difficult. And people like Alan, in fact, I think Alan and Aaron Levine are one of the only people that have actually interviewed patients in the world. I mean, we've tried, and we've had patients say, I don't want to talk to you. I totally agree with your position, but I don't want my community, it was the MS community, to know that I'm part of this. So they don't even want to be part of it. It's very, very difficult. And the other point, and I think you're touching on this, is it is part of the broader medical tourism industry, right? We have bariatric tourism happening. We have a whole bunch of other cosmetic procedures happening. So and some of it's legitimate, some of it's not legitimate. Cohen is here someplace, Glenn Cohen. I think it's very, very difficult to get a finger on it. Having said that, I feel confident saying, unfortunately, that this is a big problem. And it is bleeding into the legitimacy of stem cell field, and I think it's going to have an impact on people like John, who are, that's the point I was trying to make at the end, where it's going to create these real regulatory challenges where we're trying to stop this clearly problematic thing when at the same time we want to get stuff to the clinic. So it is a big problem, and it has, how we solve this has relevance to areas like genetics, personalized medicine, nanotechnology, a whole bunch of other fields. So I'm giving you very unscientific assertion here, but I think it's fair to say it's a big problem.
I think I did mention that there is no registry at the moment. I don't even know how such a registry would be set up. I don't know how it would be, the registry would be regulated. And of course, stem cell treatments have been offered in very many different contexts, as we've seen: anti-aging treatments, sports clinics, physiotherapy clinics, dental clinics, so we've discovered. So how would you monitor it? I've got no idea. I mean, so we rely upon press reports, we rely upon the information that's given by institutes, institutes such as Stem Cells Australia that keep records. I mean, the people, and people like Megan who are actually starting to document the number of inquiries they're getting, but it's indirect kind of information.
Yes, Irv?
So I think it's very hard to get the numbers because you're not out there advertising yourself as somebody who has got hope for the people who have lost hope. So I know from personal experience that when we first were working on stem cells, it wasn't the big Google days yet. I would get 2 or 3 inquiries per day. And now that we have something in cancer, which is not in clinical trials yet, I've had a steady 20 to 30 inquiries every day of can they get into the clinical trial. And so I think that points out that it's hard data to get, but if you have the right attractor for people who really are looking for it, you'll get a lot more. And I'll make one anecdote. I'm from Great Falls, Montana. I gave a talk to the community in plain English 2.5 years ago. Farmers, ranchers, businessmen, no university, or not much of a university. And I talked about stem cells, and for 3 minutes I talked about the unproven stem cell. Out of 180 people in the audience, 2 voluntarily came down. One had spent $50,000, the other $85,000 at what was clearly unproven stem cell therapy clinics. So that's 1% in the middle of the country. Now, admittedly, they knew I was going to talk about stem cells, but I think that we're underestimating very much how big this is. And I think Heather Rook should mention something about the when the website was really going, how many people were coming to it every day.
So Irv's talking about the ISSCR's closer look at stem cells, and when that was very first launched, we got a lot of visitors. We also had a lot of impact. We also had, before that, the ISSCR guidelines, and I think that perhaps a better way of giving some gravity to what the effect of that was is to look at Tim's data, actually, that he showed. And in 2008, when we, with our guidelines, put out the patient handbook, which really started to talk about this issue for patients as we saw it growing within the questions that were coming into our research community. That seemed to have a big impact on how it was perceived, how stem cells, how treatments were, and how the issue was perceived within the public area as well.
Well, one thing that as a clinician who does clinical trials, you know, I also take a look at what's out there, for example, stem cells for autism. And I say, you know, is it possible that there could be some manifestation of autism that could get better? And I began investigating that a bit. I mean, for example, you know, many of these trials use umbilical cord blood for really anything. And so therefore, you know, as I think about it, you know, there are regulatory T cells in umbilical cord blood. Could it somehow obviate or ameliorate the autoimmune or the component of the disease? You know, so the thing is that what I would like to be able to do in some circumstances is to be able to repeat as a real clinical trial, to be able to say, is it real or not real? So people are going out to other countries and getting umbilical cord blood for this or that. But yet, you know, for me to repeat that study, to prove if it's true or not true, is obviously a big expense and not so easy to get funded. But it is something that might be a way of at least saying, is it worthwhile or is it not worthwhile, to be able to come back with real scientific data. But it's a problem for us to consider perhaps throughout the day.
I'm wondering in these conversations whether we are unintentionally making the problem even harder for us to define by lumping all of these potential therapies in as stem cell, when we're really talking about autologous adult, which certainly has a great lesser risk of harm than embryonic and IPS, and for diseases where there's really no connection or conditions whatsoever, perhaps. And whether we actually should be more careful in dealing with the media, dealing with patients in our own presentations, to try to segment them a little bit more.
I think this is a very interesting point. I think, so my answer to that would be yes and no, because I'm a lawyer. Yes, I think that a lot of it is, and I think, George, we've had a dinner conversation about this, a lot of it is they're promising kind of regenerative response, right? And a lot of these stem cells have nothing, you know, these promised therapies have nothing to do with that. And they're just lumping in the word stem cell and regeneration into the field. But that's part of the problem. So that's my no, is that a lot of the issues associated with stem cell tourism are because they're marketing the concept of stem cell, you know, playing on the excitement to market these therapies. So you still get all the problems associated with that. Having said that, I think I do agree with you that there are if we were going to take baby steps to regulate this, we could pick, you know, cherry pick, I hate that term, but we could pick real clear examples. And going to something that John said, I also think we could probably try to pick things where it clearly doesn't work, right? Clearly doesn't work, and make more definitive statements about that reality, and then move on from there and sort of try to expand.
If I may, just a very brief comment on a topic that I'm sure will be touched upon repeatedly during the day, and that is about a comment that John just made about autism and stem cells. And I will try and oversimplify it and condense it in a statement like, well, how do we know that it doesn't work? This attitude is actually becoming very popular in the clinical community more than in the scientific community. And I think that this is one of the dangers that come from within the medical and scientific community. A role of empiricism in medicine is always defended as a value of tradition of medicine. I would gently disagree on that, and I would make a simple statement. Jonas Salk's vaccine underwent one clinical trial. And we knew, because we knew beforehand, that it does work, as we knew that it did work. Acupuncture has been subjected so far to over 3,000 clinical trials, and we can still spend the entire night discussing over green tea whether acupuncture is going to be good for my back pain or not. So clinical trials, as much as we can make them rigorous, I would like to gently submit, are not reproducible experiments by definition. So we should consider whether, when facing the possible, can stem cells actually cure ALS? How do we know they don't? That maybe, as much as legitimate is the question, the answer is not in a direct approach to clinical trial, but rather in the usual road through solid science.
I'm willing to respond about just about anything, and I actually I think I agree 100% with what you said. Look. If you look at the history of science, people bring up antibiotics, bring up vaccines. You know what? In general, it's a pretty blanket statement, but I'm making it anyway. Nothing works, right? It's very, very rare. I mean, there's been really interesting research on this. It's very, very rare for an animal study to work, for a clinical study to pan out. It's very rare, and look what's happening with stem cells. This is a complex field. So I think I completely agree with you. I think we need to make, I think this is what you were saying. We have to make bolder statements about what the science says, what the possible mechanism of action could be in this context. And maybe we disagree on this, but I think we need to be really careful about it. And look, it's safe to say this stuff doesn't work because that's what the science, the background of science informs us, and I think we have to be bolder about that. Did I interpret you correctly? And maybe we disagree on that.
Can I just make one brief comment about that too? Very interesting observations you're making. Of course, there's a very rich history in medicine using the case study. Barry Marshall's work, for example, on stomach ulcers a few years ago, won the Nobel Prize for that work. You mentioned Salt's work. There's actually quite a rich history. But when the stakeholders that we're talking to talk about evidence, they're talking implicitly about a certain type of evidence, a randomised double-blind controlled trial, I think. Of course, we're not seeing the kind of the systematic reviews or the meta-analyses, which I think is sort of the top of the pile in terms of standardised forms of evidence around stem cell treatments. When the patients we speak to saying they receive that they're experiencing some improvements, you have to understand too that they're often undergoing physiotherapy. They're sometimes exploring complementary and alternative medicines, and we don't know what the mix is of the interaction between conventional treatments and these other forms of treatment. There's an interesting thing happening in Geeta Shroff's clinic in India at the moment, and Amit Prasad, University of Missouri, has been spending quite a bit of time hanging out with the patients there, who almost to the person are reporting improvements in their well-being. Those patients spend a lot of time hanging out together. They form a very sociable environment, and there seems to be something happening there. Almost got a cultish aspect to that context. But he's saying, it is quite interesting, social scientist, and I did wonder, and he did speak at an event I organised in Prato, Italy, a couple of months ago, and I did wonder whether he'd gone native because he'd spent so much time hanging out at this clinic. But the patients there were reporting improvements in their condition, and there are other things going on besides the stem cell treatment. You have to understand that. So I think we need to unpack what we mean by evidence and what counts as evidence. So I think it's a very interesting point that you're making.
So I guess I would like to take kind of the other side of some of the comments. I think that if we accept that there's a lot of variability in clinical trial design and clinical trial practice, and that inevitably leads to differences in terms of outcomes and observations in the clinical landscape, I think that's a good place to start. But I think that if we go beyond that and say it's impossible to run rigorous clinical trials that are going to lead to a meaningful assessment as to whether or not a therapy is safe and effective, then I think we've entered into very dark territory. And what I would argue is that we need to take a fresh look at the clinical path as it exists today and make a determination about how can we actually improve the efficiency of the clinical path to deliver therapies that are able to meet the needs of patients that are suffering from severe unmet medical needs. But we need to hold ourselves to a fairly high standard, and we can't give into the temptation to say we're going to hang our hat on anecdotal experiences or case studies. I mean, I'll put it in human terms. So we have a program in heart disease, and we have programs in a number of other areas, and several years ago I got a call from someone who said, I'm really encouraged by the work you guys are doing in heart disease, and I just recently got back from a trip to Thailand where this person happened to be a retired executive, had a lot of money. They paid $150,000 to actually go to Thailand to get an injection of stem cells to treat their congestive heart failure. And I said, what is it that would have actually persuaded you to do something like that? And he said, well, they showed me 2 case studies. One case study in a patient where there was some benefit or apparent benefit, and another case study in a patient where there was no apparent benefit. And I said, and I asked him a series of questions, do you really believe that that's a comprehensive enough data set to be able to justify getting on a plane and traveling halfway around the world to spend $150,000 on an experimental therapy? And he said, realistically, no, but I have the means to do it, and I'm desperate enough where I know if I don't do something, then within a couple of years I'm probably going to die. And he said, I can't afford to wait for therapies to go through the regulatory landscape to get the approval so that I can actually get treated. And I think to me that encapsulates a lot of the problems that we're talking about today. And I think a related problem is, can we create a forum or a vehicle for patients to get access to better information so that they can actually educate themselves in non-scientific terms or in layman's terms, but yet end up being in a better position so they can decide, is it in the best interest of their medical future or their child's medical future? Because that's really where I think a lot of the problems are. The people that basically are going to spend their life savings on therapies that there's real no basis for believing that it's going to work.
We've had 2 questions come in from our internet participants. One's from Israel. I'd like to read it and ask one of the panelists to give a quick response. The discussion, this is from David Walker from Bloomberg News, Tel Aviv. The discussion has focused mostly on small clinics which exploit patients' hope with unregulated treatments that have not been approved by regulators. At the same time, there has been a proliferation of legitimate stem cell companies developing treatments that undergo regulated clinical trials. One can see some very strong language from these companies in their press releases announcing trial results. I wonder if the participants here think that some of the larger companies have been hyping stem cell treatments and what the consequences might be for the industry.
Yes.
I just wanted to say one thing before we move on to that. I apologize. I thought I was going to, because of the question that had just been asked previous. And it goes to the purpose of this meeting, and I just want to bring us back very briefly to that. I think there's 2 parallel lines of endeavor that are important. One is to help the regulatory process through the development of the interstitial regulatory science that's needed to make it possible to regulate more efficiently. There's a world of scientific material that needs to be developed that would allow regulators to effectively and quickly understand what is a safe or unsafe manufacturing process, what's stable, what is going to be replicable. There's a million of these smaller questions that don't necessarily get people tenure, and so don't necessarily get the attention of academics. And so that's one area where developing a research agenda that would help the regulators fill in those gaps so that they can move forward would be helpful. It's not the purpose of this meeting, but it's an important thing to do. It's a different kind of thing. What we're talking about here today is really what to do in the meanwhile, before that has happened and before the regulators can move forward as well as they'd like to. What can we do to help assure the best possible experience for patients overall? And that's why the focus has been where it's been.
Thank you, Alta. Would anyone like to respond to Mr. Walker's question that I just read? We have one other as well.
Yeah, I could actually.
Alan
or
Larry?
So
Yeah.
I know anecdotally of at least one case where a phase 1 stem cell clinical trial was being done for a condition I won't name, and where the newspapers miraculously, the reporters miraculously found one of the patients who thought they had done much better after the trial treatment. So I think to some extent we do have some of the same problem that pervades our own industry. Our institutions would like to issue press releases. We all like to be hopeful. I think we need some guidance on what is appropriate language ultimately, and when we don't have that.
I absolutely agree, and I think there's some evidence that I call it the cycle of hype that it happens. I think it's gotten better in stem cells. In early days, it was terrible. Where we had these time horizons of 3 or 5 years where we're going to be in the clinic, and we have lots of examples of that. The pressure to commercialize is intense, and it's intensifying, I think, in all the OECD countries. And so, yeah, absolutely, I think this is a problem. And then, of course, the illegitimate companies can leverage that language.
Can I mention also that, with news releases rely heavily on public relations, information coming from public relations generated sources. Most organisations, I presume International Society of Stem Cell Research and Stem Cells Australia and similar organisations have a media arm. Universities do. I know my own university, Monash, is very keen to broadcast exciting new findings. In fact, that was the problem that the scientist whose name I can't remember at University of Newcastle upon Tyne encountered a few years ago when he left the university. He actually left and went to Spain because the university was what he saw as being overhyping of his research findings and building up patients' hopes. So, and Jim McNamara in Australia has done some work on the links between PR and news agencies and found out about 70–80% of news stories are generated by PR agencies. And it's a very broad term, PR agency. So I think we need to reflect upon that.
What if I could make one last comment on it, and then I do have a question, actually. And the comment is just, I think we all have had the same experience. We get whiplashed. On the one hand, patients say we don't offer enough hope, because we're too pessimistic, we're too critical, and on the other hand, we get criticized if we're too hopeful. And I think how we find that middle ground as a community is, I think, one of the long-term outcomes we're going to need to develop. But I don't see a simple answer there. And that relates to my question. Rusty brought up what I think is the very legitimate question of, what do we know quantitatively? If 100 people are given the same kind of information, what fraction of them actually decide to go off to China or La Jolla or wherever the clinic is, and what fraction of them take that information and use it in what we would consider to be a realistic way? Part of this goes back to research on decision-making in people, in economics and sociology, and it's in fact a very complicated area. But I wonder if one of the outcomes of what this exercise is today is that we ought to, before developing a long-term approach to the problem, try to learn something about how people are using this information. I don't think that you actually have to follow precisely only the people who actually go to a clinic. One could develop a sociological study, I think, or a series of studies that could evaluate how people use this kinds of information when they're confronted with a situation of X, Y, or Z. And so I just wonder if the sociologists among us could imagine doing something like that.
Hang on for just a minute. We have another question from the internet participants that I want to read because it relates to what Larry just asked. This is from Alan Regenberg at Hopkins Berman Institute of Bioethics. It's, where and how do you think resources could most effectively be directed to minimize the harms related to the use of unproven stem cell-based interventions? For example, communicating with patients, providers, improving oversight. That is, we've identified a problem, but what do you think is the best strategy for addressing it, including what Larry said about the need for some fundamental research? One of you has already commented that simply providing information to patients doesn't overcome their desperate need for some intervention.
Just responding to the previous question, I mean, the idea of providing a package of information is based upon a premise and a certain assumption about patients and the way patients understand information. It's sort of a very economic kind of argument. In economics, of course, we have the rational actor model, and it's assumed that if people are given the requisite form of information, that they will act in a certain predefined way. But of course, this doesn't take account of the affective dimension that I was talking about, the issue around hopes, for example. It also is a deficit model. It assumes that if people were given more information or if they're given correct information, in other words, the assumption is that they're ignorant, they just don't know the true facts, that they would act differently. So there's something wrong, I think, or there's something limited in the way that we think about the issue in terms of just giving people a package of information. I'm not saying it's completely useless, but it's rather limited. And it also takes the gaze off all these other factors which shape decision-making that I referred to. There's sort of the development of expectations which are generated by various constituencies. I'm developing a paper at the moment called The Clash of Hopes because the patients and clinicians have their own hopes and they often don't correspond. Groupman, for example, in his book The Anatomy of Hope, talks about the therapeutic value of hope in decision making. This is quite an important sort of angle on hope. When patients talk about hope, it's something quite different. We don't really understand what's going on. I'm quite shocked at my own discipline, sociology. The sociology of hope's underdeveloped. I'm writing a book about this at the moment. You'd think that there'd be very rich literature in this field, but there's not. So I think we need a multifaceted approach to understanding the issue, and rather than just thinking about more information, better information, and sort of identifying the institutions that should be charged with disseminating that information.
Okay. For the last comment, Ellen Feigl, and then we're going to take a break.
Yeah, I was just going to comment is for us not to be, I know it's not intentional, but not to be over-patronizing about the ability of a patient or a consumer of these services to understand. I think a big part of the blame is really on the professional community not to talk in English or not to present things in ways that actually they can engage in. And the other part, when we think about education, it's really not particularly relevant to clinical trials right now, but I think of all the tobacco information, and there really is a cognitive dissonance. You can put a lot of information out there, but it doesn't necessarily follow that the decision not to use something or not to do something is going to naturally play. So I think communication is a part, but there's a whole variety of other things we need to do in addition to communication. Thanks.
Let's reconvene in 10 minutes. Thank you.